I'm just going to start by thanking everyone again for inviting me and just talk a bit about the background to the UK LLC before I dive into the detail. Here we go. Okay, that's fine. Yeah, no, that's fine. Okay, right, scrub that. I'll start from where I plan to start. So my name's Andy Boyd, thank you. Director of UK Longitudinal Linkage Collaboration based at University of Bristol. Everyone puts up a slide like this at the beginning of their talk and then quickly moves on. I want to just dwell on a couple of things because, like Anne, I think it's important to look back and to do a bit of reflection on where we came from to look at where we're going to go, which is going to be the bulk of this talk. And two things I want to point out. So we're run by Bristol and Edinburgh, but this bit here about Swansea and SERP. We wouldn't exist if it wasn't for SERP and all the effort they've put into developing that underlying technology. And the collaboration with Ronan and David goes back to mid-2000s, so a really long established collaboration with Swansea, and delighted to be in Swansea giving this presentation. The second thing is this logo here. The origin of the UK LLC is, we were sort of a long anticipated innovation. There's been talk about this sort of functionality, which I'll explain what we are in a moment, for a long time. But suddenly the pandemic hit and it became critical that something existed very, very quickly. And an amazing person called Nish Chaturvedi from UCL led the program called the Longitudinal Health and Wellbeing National Core Study, funded as a strategic capability by Patrick Vallance, all in a hurry, huge amount of effort put in, and many thanks to Nish and the team. Okay. I'm not going to start by talking about UK LLC. What I'm actually going to talk about is the stars of the show, which are the UK's longitudinal population studies, or LPS. And many of you know those as the cohorts, or what's being termed now the consented cohorts, because we're now in this new data science world, we're starting to use the word cohort in lots of different ways, so it's getting a bit confusing as to what a cohort is. But these are the cohort, this is what comes to my mind when I hear the word cohort. And they're studies generally with an interdisciplinary background and basis, integrating data about health, socioeconomic and demographic situations, environmental factors, genetic and other biological factors, all into routine databases. But our USP as a community is we're following up groups of individuals with a shared characteristic, generally over very long periods of time. And it's this. To do that, you need to have a bond between the study and the participants you're following. And that's the gold dust in these studies. It's the trust relationship between the participants who are completely not paid or incentivized to do this from anything other than just pure altruism and wanting to improve the public good. And they commit, as we'll see in these examples, to lifelong follow-up with an amazing amount of dedication and hard work, permitting studies to collect data on them and supporting studies through their research journey and innovations. So here's a few different studies, which I just want to highlight the diversity within this community. So here, Nish Chaturvedi's cohort at the top, the 1946 cohort. So every person born in a particular and secret week in 1946 was eligible to take part. And they have done ever since. So this is true lifelong follow-up. 46 cohort is now known as a genetic environmental determinants project. When these people were born, Crick and Watson hadn't even isolated DNA. So there was, it just shows the transformation. Even children of the 90s, where I worked for 25 years, children born in the Bristol area in early 90s, that was a paper-based system up until age 8. We had 2 computers running the whole study when I started there, which makes me feel old, I've got to say. But it just shows the progress across in technology and the world around us. And these participants have come on a journey with us, stuck with us, accepted all these different changes, and been on a journey with us together. A couple of other examples. Born in Bradford, children a bit younger than Alsbach in Bristol, but in the Bradford area. And the innovation there is baking in the cohort into Bradford's health trust systems, into a learning health system, where the data science, which a lot of you are familiar, using routine health records and social records, is baked in with cohort participants just to give another tier of detail and richness. And I'm going to talk about that richness and tier of detail a lot in this talk. But that's a wonderful model where very mixed community coming together to further the public good. Two studies here which are really interesting. Another birth cohort, this time from the 1950s, an Understanding Society. These are nationally representative samples. So pan-UK follow-up of people deliberately selected so they represent the population at large. So trying to overcome the sorts of biases that Anne mentioned just then. We got twin studies as well, looking at environmental, the whole nature-nurture question. Wonderful studies here. You've got GLAD, which is a large volunteer cohort of people self-identifying with mental ill health. That was sort of recruited directly through the internet. Very dynamic cohort, lots of young people, constantly recruiting and evolving. And then you've got occupational health cohorts. So Airwave is an example of that, where you can start looking about the interactions between work-based pressures and exposures and mental ill health. So really diverse set of studies in this community. I've been putting this statement up on this slide for quite a long time. There are somewhere between 50 to 100 studies in the UK. No one knows how many, which is a bit weird. Louise probably has the best idea and the best list, but I think I know a few which aren't even on that one. But no one knows exactly. It used to be fair to say there were 2 to 3 million members of the UK public in a cohort study, but now we've got Our Future Health, which is planning to recruit 5 million alone. This is a substantial subset of the population. And some stats here from a recent audit conducted of longitudinal study data use. In a 5-year period, over 100,000 data sets downloaded for use by the research community, data sets generated by these studies. And what is it? Almost 17,000 academic publications coming from that data in 5 years. It's a treasure trove. It's absolutely wonderful. These studies, like Children of the 90s I know best, they've collected information on virtually anything you can think of with exceptional granularity and detail. So I wrote up the cohort profile of Children of the 90s when the children turned age 18. By age 18, that study alone, those children had had 125 direct assessments by the study. And these aren't trivial little bits of data collection. These are booklet questionnaires, 50 to 60 pages long, or whole day visits with psychological assessments by clinical field workers, anthropometry, blood donation for genomics, and so on. The depth of detail, Elsbach alone has something like 2 billion data points, if you look at it across all the variables and all the participants. Phenomenal data sets. So that's why I say these are the stars of the show, not me, not LLC. I'm going to say why that helps, but these are the real stars of the show. But as I mentioned, we were thinking about a new way of working, and there was a reason for this. Anne alluded to in the opening statement how it's been hard to get access to data. I'm not going to dwell on that story because we want to move that story on, so now it's easy to get access to data, or easier, let's put it that way. It wasn't working in all these studies for one reason. They were doing a brilliant job of talking with their participants, enthusing with their participants, getting the governance right with their participants, and collecting data from their participants. But what we also wanted is a new perspective, a different perspective on those participants' health and well-being. And we can get that by linking participant data to their routine records, their health records, educational, criminal justice, employment and earnings, environment, about air pollution and so on. The world's your oyster. But a lot of these studies are relatively small. Some of them are led by a clinician and a couple of dedicated nurses and don't really have tons of data management staff who can bang their head against the data access system and work their way through all the governance labyrinth which allows you to get hold of data. Now there's a couple of studies like UK Biobank, you probably heard, and Our Future Health, who are massive, hundreds of millions of pounds worth of funding. They're fine, they're doing great. Some of the other studies like Children of the 90s where I worked and Generation Scotland where my co-director Robin Flake worked, were well resourced to do record linkage, making progress. Lots of these studies in different examples have set precedents and pushed the story on, doing great stuff. But the smaller studies, there was a barrier to entry they just couldn't manage to get over in order to do record linkage. So what we needed was a centralized service where studies could deposit data within a secure location. And in that secure location, we could centrally manage record linkage as a service to the studies to reduce pressure on their staff and their PI time, to reduce costs to the system of the duplication of effort across lots of studies, but also to reduce the burden on data owners. So at the moment, you had 50 to 100 studies all going up to NHS England saying, can we have your data, please? And actually, we got 50 to 100 slightly different ways of doing effectively the same thing, which was just clogging up the system. And in COVID, they were on their knees. They were just helping so many people in so many ways. They couldn't possibly do it in a diverse set of ways. So what we decided to do was to come together to build a TRE based on UK SIRP kit, but a bespoke governance layer which was suited to the record linkage studies in this community. And it has a couple of really distinct scientific advantages. So the first word here, going back to, again, something Anne said at the beginning, highly heterogeneous sample. So you've got some very large cohorts like Biobank, which are amazing and doing a wonderful job, but they're predominantly white and skewing towards healthy and higher socioeconomic study. They're volunteer cohorts. There's a pattern inherent in that. And they're doing a very good job for what they're designed to do. In fact, a phenomenal job. But what a lot of these studies do is to, like Born in Bradford or Sabre, which is a community in London, is look in depth within diverse communities. And by bringing together and co-locating all these different samples, we can pool all this wealth of data, all this diversity of sample in one place, and build statistical power to look at rare events and outcomes, but also to do subgroup analysis within different populations and different groups with different lived experiences, and make the whole process more equitable and fairer for the UK population. So the challenge, I guess, in this bottom paragraph, picking the sort of the bones out of it, is when you do that, when you co-locate complex data, there's a harmonization challenge. And that's something which we're working hard to make easier, but bringing and integrating data from all these different sources is non-trivial, and we can explore that in a moment. But what we can do, again, through this TRE, is systematically link the routine records, so at least that is equivalent across all these studies. So that gives a reference point, a benchmark, where you know the data provenance from the link records, whichever they are, and I'll come to that in a moment, is equivalent across all these individuals. And then you can start identifying the study data and linking it through and doing your analysis, triangulating across these two different distinct data sets. But I talked about the gold dust being the participant trust relationship between participant and studies. What we didn't want to do was this new way of working is undermine that trust. And we took the view that if we were going to do this, it had to be a TRE. I'm guessing most of you are familiar with this new concept of TREs. This is where the data sits in a secure location, in this case, just over there somewhere, and researchers dial in and access it there. The days of data flying around on CDs or by download are finishing, and researchers have to be accredited, they have to be trained, they have to come into these safe environments, and they see and access the data which is relevant to their projects. So that was obvious as a design choice. And it's wonderful we can also then go on to talk to the participants that this isn't an erosion of their rights. It's still the study who determines whose data is used for what purpose, which is key to the trust relationship, but actually it's a strengthening of their rights because we're able to ensure data security in a way that the old way of working, where data was flying around in lots of different places, was working well, but this is a clearer and more transparent and safer way of implementing those same objectives. So, this new way of working. In 3 years, we've set this up from scratch. It's built, it's fully operational. We've had projects go through the whole life cycle, and we've now got publications coming out, BMJ and Lancet and all those different good places. This is what we've pulled together in that time. At the moment, there are 24 big longitudinal studies with, I think that number's quite out of date now, about 300,000 participants worth of data in the system. But the studies who've already signed up have got, by the time we finish setting up the permissions with participants, it'll probably be double that. And since we were refunded, more on that in a moment, another 25 studies have asked to join. So this sample could easily grow over the next few years to well over 1 million. We've got, in potential, with the study contributors, the broad range of data that they've collected and deposited within the system. We've linked, in England and Wales, and an application in Scotland to do equivalent, the breadth of primary, secondary care, prescriptions, registry data, COVID-19 data, obviously, because that was our initial focus. And for the first time in 15 years, and based on this model, departments like HMRC and DWP are now agreeing to deposit socioeconomic records on employment, earnings, benefits, welfare, pensions. We want to extend this to education records, and that could also set precedents for linking to more diverse non-health records, such as criminal justice or children in the care system. We're geocoding participant address data, so we can link data about the natural environment. Perfect. And also about the areas and properties in which they live. Finding this data can be challenging. We've got a data catalogue we're launching. We work closely with Louise Arseneault on her wonderful data catalogue, which sets all this out in detail. And we've just got this grant with the equally wonderful Bettina Moltrecht at UCL, who's developed this fantastic AI-driven tool which allows you to identify comparable data within studies across time and across studies to make that harmonization and data discovery piece work more effectively. And we've just got a grant which is going to tie up all those systems together to make discovery a much easier system. And the sorts of depth Louise has gone to in working through the cohort, identifying all the mental health data and setting it out in this really systematic and clear way, saying for, in this case, GAD7 has been collected at these time points and across generations. Our objective through this, and over the next couple of years, is to characterize each of our participants' mental health journey in terms of healthcare service interactions. Primary care, secondary care, community care, through to registries. And this is an English perspective, so the acronyms and names slightly differ in the devolved nations, but to be able to understand the journey from GP consultation through the different pathways and the different outcomes resulting from that. So we've got all that data. The GP data in England, there's a big question mark about that. We have GP data for COVID research, and that is being used for mental health purposes because it's understanding the mental health impact of the pandemic. But we're waiting for a broader solution in England for GP data. Access. So, like most TREs, we follow the 5 SAFEs model. I can talk about that in the questions if you like. But we require users to be ONS accredited. And what I want to highlight is from submitting an expression of interest, then a full application, data provision in 8 weeks. That's our average turnaround time. One form, we manage all the background negotiations with the data owners. So it's one form for up to, at the moment, we've got something like 42 different data owners in the system, and we deal with that complexity, so you don't need to. That's the sort of power this centralized service has. There's a stop the clock moment for your institution to sign the contract, by the way, in there. I'm not taking responsibility for that. Working in the TRE, it's a Windows environment. Lots of people who aren't familiar with TREs might hesitate. You dial on, it looks like your computer. It is just a Windows environment. We've got all the data science tools in there like R and Python and SQL, but we also have Stata and SPSS. And we hand each individual who comes in as a user automatically generated code which turns the database data into SPSS or Stata formats if that's what they want. But if you want to do the hardcore data science stuff, fill your boots, all the tools are there as well. We're building Git resources to reuse data. 1 minute or two. to make it more efficient to build on the shoulders of others, the work that's already gone, do follow-on replication studies, reshare syntax and code lists. One thing I want to talk about, I guess very, very briefly, given the time, is the sorts of tiers of detail. One thing we identified in the pandemic was an analytical approach where you can work by looking in the whole population databases, like Sale Databank in Wales or Open Safely, to identify patterns and associations. You can even explain a lot of those patterns and associations, but you can't get to the background behaviors and aspirations and drivers which influence quite a lot of those. So what we think is an amazing way forward is to do that whole population assessment and then a deep dive into longitudinal data, where you've got that self-reported data which helps you understand some of those patterns. And I can talk more about that later. But this study, initially the same researcher looked at Open Safely, 56 million people's GP data, to say, did COVID healthcare disruption lead to changes in avoidable hospital admissions? They found nothing, because they were modeling healthcare disruption just on, we were in lockdown in these weeks. It's a very crude measure. Using self-report data on my healthcare access was disrupted, we found very strong signals and social patterning in it. So it's that added detail the participants give, which give you a new lens on the research question, which you can't find in the research data. Our future, refunded for 5 years, developing an omics platform with SERP. We're going to improve the user experience, working with the ONS to link in those admin data, and really just working with our partners, the longitudinal studies, to make all this richer and better. That's what that says. I always miss this slide out, and it's really, really important. Not this slide, the one I've missed out again. It's free. That's my last slide. And thank you to the studies and the participants.
Andy, you can take a seat over there. I think that we're going to ask you a few questions. We have 10 minutes for questions. And while you're thinking about your questions, maybe I will ask the first one. I think that you kind of really outlined so beautifully all the work, all the partners, all the systems that you've been working with to create something as beautiful and useful as what you did. Can you tell us the biggest challenge? You know what, in all the work that you did to develop that, what was the biggest challenge?
Oh, that's a tough one, isn't it?
I look nice, but I'm not.
Yeah, I'll remember that as well. So it isn't what you'd expect. We sort of knew how to do this. We were scaling up the success of ALSPAC and the success of other studies endeavours. And what happened beautifully is we all came together under the pandemic to jointly do this and to tackle it in good faith. Lots of enthusiasm from the partners. Also, lots of enthusiasm from the data owners. You'd have thought that was really challenging. So I guess, answering the question, it's not the things we would have expected. It's more data provenance, understanding the data journey. There's a huge amount of data in there. And it's all very complex, and it's all come from different places. So it's being able to trace that data journey. There's data sets I mentioned there, like MHSDS, which is basically a record of transactions between patients and community mental health care data. No one really in the country knows how to get the most out of that data set, or what it means and how to deal with it. It's 56 separate tables. So that's something we're going to be working on over the next couple of years. But that's one of the big challenges. It's that data provenance. We've got some also big intractable problems, or seemingly intractable. GP data in England, that's one. Although there are solutions emerging. So I'm hopeful. I remain ever an optimist. Otherwise, I wouldn't be in the data acquisitions game. And and things like making sure that we didn't erode that participant trust relationship, and how things like consent remains valid as things change in contextual terms. So those are challenges, but studies have been doing that for decades, so they're on top of that one.
Absolutely. That's great. Thank you. Would we have, yes, Tom?
It's absolutely inspiring. Very, very cool to see.
Thank you.
point you made there just now about kind of best practice for the researcher who's trying to answer a particular question using a potentially incredibly powerful set of linked data, but where there's all the harmonization challenges and even just interpreting the context of any given data point, the way it was created to inform their conclusions. And it's great to hear that you guys are working on that, but it feels like a big task for just the kind of data aggregators to be working on. Are you aware of funding or programs, or do you have ideas about ways that we collectively could be supporting that so that the researcher can come in and just get on with answering their question rather than having to kind of sort of go back to first principles and do all the harmonization work themselves?
Yeah. You're right to identify that as the challenge. And it's multidimensional. So there isn't a simple answer because the challenge has different steps. So one of the primary ones are data discovery. And I alluded to the fact that we are really working on that. Louise has done a fantastic job in mental health. LLC is a generic data bank. So 2 days ago I was at a respiratory health conference, and next week I'm at occupational health. So, for us, it's like, how can we scale Louise's work in mental health to other domains? So that's one. And then, but the work Bettina's doing on that AI data discovery, that's amazing. Integrating our catalogs, that will make it a simpler journey where you've got one entry portal, and then you can go to the different tools which do the different jobs, but it makes it easy for the user. So that's one thing. Tools for harmonization, capacity building, best practice. We need exemplar scripts, we need training videos, we need self-help resources which explain the challenges and itemize them. So those who aren't familiar with using cohort data can get their head around what those challenges are. We're working on that as well. But I think to get to the real heart of your question, I think the answer has to come from the community. There's no way my team of 10 can build that systematic, holistic knowledge base that you are referring to, but all those thousands of researchers who published those 17,000 papers and downloaded 100,000 data sets, they've got the capacity to do it, and they've got the skills. You've got people like Anne, who's an expert clinician in that field and understands the data from a clinician's perspective, where I don't. We need to capture that somewhere. And there are some examples of where that's working well in practice, but I think that's the answer there, is a community-based approach. And that's got all sorts of things to unpack about it, about how you incentivize that and fund it across all different research projects. But I think that's the heart of the answer.
Thank you. Oh, okay. Rob.
It's excellent and it's well needed, but sometimes in applications there are difficulties you can encounter if you're the only country that can do something and other countries can't, and therefore they're less interested. Do you have kind of sort of key international partnerships of places that have similar or sort of type of capability or going in a similar direction? Because there is a danger in the UK going all alone in the rest of the world doesn't have much of an interest because they feel they can't. And
that's a really good question. It's something we haven't put as much energy into because of focusing on the pandemic and the fact that national data sharing permissions generally are for UK-based researchers only at the moment. But it's something we want to look at. So we are developing networks with European colleagues. And also, in fact, I've got a call Monday morning about an Australian initiative which is looking to do something similar. And you could envisage this over time being nodes in a globally distributed meta sort of system, where you've got the cluster of Australian longitudinal studies or American ones, for example, and European ones, providing different perspectives on their population. And within the longitudinal community, there are examples of that. There's the American-based longitudinal collaboration of healthy aging, of which ELSA and Nicola in the UK and Haggis in Scotland are members of. So that's prospectively aligned cohort data collected across the Western Anglo-Saxon world at least. And to be able to think about how we could join those up in different ways with the linked data systematically, that's maybe the next step on that journey. So I completely understand where that question's coming from, and having that international outlook is going to be really important.
Great. I will not encourage any more questions. Do we have any more questions? I cannot see. Oh, Francis. Cannot say no. Yeah.
really interesting. Longitudinal data, I wonder if people are doing this for other types of data, thinking particularly about trial data and maximising outputs from those sorts of studies.
My understanding is the national NHS SDE, which is Secure Data Environment, which means the same as Trusted Environment, it's just the NHS term, is meant to do trial follow-up. And we've got partners who also work with Swansea, who are looking at Risha Sofat and Kathy Sudlow, who are setting up something similar to look at clinical cohorts. So yes, there are a few other initiatives, and we need to share and not duplicate and do all those things.
Great. I just want to respect the schedule, otherwise we will accumulate delay, and I think that people will not be happy about that. If you have any more questions, we have coffee very shortly. I'll be the first one in line to ask you more questions, so that's great.
I'm here all day,
you.
so
Thank you so much, Andy.
Thank you.